that you guys have learned about. I want to talk about status asthmaticus and how we manage that is critical care nurses or advanced med surg nurses. We're also going to talk about pneumonia, but we're going to talk about it more on the ventilator acquired pneumonia. In the critical care environment, a lot of patients are intubated, and we need to be aware of complications that can arise from that intubation and how what our role is to prevent it. And then we're going to talk a little bit about COPD. COPD is a block 1 concept that you guys have kind of you know about blocks 1 and 2. We're going to talk about more end stage COPD. So first and foremost, I want to talk about airway obstruction caused by bronchial asthma. Episodic airflow obstruction results because these irritants cause bronchoconstriction, airway edema, mucus plugging, and airway remodeling. There is a figure in the Soul book in chapter 15. It's figure 15-5. That's the one here that we're looking at. So some of this content will be out of the Soul book, but a lot of it should kind of be review for you as well. You guys can read over these. Asthma is often well managed, but in acute episodes can result in admission to the hospital. The symptoms can vary, obviously, and depending on the severity of it will depend on the treatment and the course of treatment. So if if they're not able to move air, and you can assess that based on listening to their lung sounds and watching their vital signs. If they're having a lot of chest tightness, using accessory muscles, we want to make sure that we help open up those bronchioles. So we're going to need bronchodilators, and we're going to need continuous bronchodilators for this patient. So it's not uncommon to be on a continuous SVN treatment when in true exacerbation occur. Potentially their inhalers or what they have at home, bronchodilators are no longer working, or they may have some non-compliance with medications. Because of that, hyperventilation can occur, and it can actually trap air, resulting in a respiratory acidosis. They can become severely hypoxemia. A common cause of exacerbation, most common, is non-compliance. Steroids and bronchodilators are the most common treatments. You want to make sure to teach the patient to implement environmental controls to prevent symptoms. So a lot of times there's an allergen or there's something that triggers it. We want to make sure that they're aware and that they're avoiding it. They need to understand the difference between medications that relieve and control the symptoms to proper use of inhaler devices, and how to monitor exacerbations or when something triggers them. If it's an allergy to grass, for example, that they need to be aware that if they are going to be in that environment, that they need to bring their inhaler with them, that they may need some antihistamines in relation to the inhalers to kind of help them. Specifically with pneumonia, there's different types. We know that there's a community acquired, healthcare acquired, hospital acquired, and then ventilator acquired or associated. People that are at increased risk for developing these pneumonias, regardless of the type of pneumonia, elderly, alcoholics, smokers, anyone with chronic diseases, head injury, someone that takes immunosuppressive medications. So specifically for today's purposes, we're going to kind of go into that ventilator-associated pneumonia. You're in the critical care setting, and that would stand for ventilator-associated pneumonia. This can be because of aspiration of bacteria. This can be something that we introduce to them. Most commonly, if you think of why people are intubated, our most common VAP cases are trauma patients. These trauma patients aren't normally NPO when they decide to be involved in a motor vehicle collision or an extreme sport of some type or whatever their trauma involves. So a lot of times these people actually aspirate their own emesis in the intubation process. I've had patients ventilated that have actually thrown up around their ET tube because of just being nauseated. So these patients, it can be bacterial from their oral mucosa. During intubation, that tube goes right down into their trachea, and if they have any oral infection or anything going on, that the ET tube just passes right through that oral cavity, and that can be introduced into the airway as well. It can be kind of involved depending on the patient. So there's many potential causes. We talked about that. Um, it can sometimes be difficult to diagnose accurately. We can see that the patient has pneumonia, but to determine if it was ventilator associated or not can be difficult. Um, the CDC is all over this. This is one of the gold standards on making sure that we prevent this in the hospital setting. And again, if a patient obtains a ventilator-acquired pneumonia while in the hospital is at risk for eating the cost of treating that ventilator and associated pneumonia. How they can acquire pneumonia, inadequate disinfection, that can be not properly cleaning the patient's oral air, part of the VAP bundle you'll learn is brushing the patient's teeth and cleaning their mouth regularly and suctioning their mouth anytime you're going to reposition them. And then anything that we as healthcare providers can introduce to them: improper hand hygiene, dirty gloves. Maybe we did something else in the room and then we went to do trach or ET tube suctioning or something like that. And then contamination of the environment. So the respiratory equipment. So all those things need to be changed out timely. There's time frames on the tubing and the suction canisters and how often we change their toothbrushes and all of that. It's been 10 years. I did my capstone project on ventilator-acquired pneumonia and how to prevent it. Actually, in our ICU, we had a big kind of promotion on trying to decrease our VAP numbers, and we created these t-shirts. Actually, me and one of my colleagues created this t-shirt, and it was Zap That VAP, and then on the back of it, it went over the entire bundle. So the bundle includes making sure the head of the bed is elevated 30 to 45 degrees. If they do have emesis, if they do vomit, if they're higher risk of aspirating even with the ET tube in place if they're laying flat. It decreases the incidence of aspiration the more the head of the bed is elevated. We want to make sure that these patients are woken up from sedation daily, if not twice a day. That's usually the common protocol, at least once a shift, depending on what's wrong with them or what's going on with them. If you need to obtain a neuro assessment in the neuro ICU, you'll see them wake them up sometimes hourly. But we want to make sure that we are assessing them and that the goal is that we want to try to wean them off the ventilator to get them extubated. So waking them up daily is really important to not oversedate them or keep them on a dependent mode of that ventilator. We also do stress ulcer disease prophylaxis. So these patients will be on a Nexium or a Pepcid or Protonix of some sort. Again, there's two reasons for it. We're putting them in a stressful environment. They may not, their body's under stress. They may have tube feeds or not, but their normal routine has been interrupted. Now they're put under stress for respiratory distress issues. Also, it changes the acidity of the stomach acid and makes it more alkaline. So if they do aspirate or if any emesis does get into the airway, it can be less toxic or damaging to those lungs, causing further need for intubation and ventilator support. Also, venous VTEs, thromboembolism prophylaxis. Again, these patients, you have to think of all aspects of patients that are ventilated. They can't eat on their own. They often can't go to the bathroom on their own. They're unable to reposition themselves. They can't give themselves hygiene, baths, oral care. So you really have to anticipate doing all the things for them that they're going to need. So they need SCDs on, and they need to have a VTE prophylaxis depending on why they're there, what's going on with them. The doctor will order both. Also, oral care needs to be done regularly. It is recommended that chlorhexidine is the medication of choice used for oral care. It helps decrease incidence of bacteria. Again, we want to clean that airway best we can. Any saliva or anything growing in the mouth, we want to prevent any infection. So if the patient does aspirate around the ET tube, that it's not a bacteria a lot of bacteria present. So that's the VAP bundle. So elevate the head of bed, make sure that we're working towards early extubation when appropriate, preventing any stress ulcers, DVT prophylaxis, and oral care. After patient care. Surveillance, and I think part of that is being aware of other patients on the unit or when helping with other patients. Ventilator bundles, which we talked about, prevention transmission. We want to make sure that this is more, depending on the facility, this is more something that that respiratory kind of focuses their attention on. So sterile water in the circuit of the ventilator. Their drain consolidate away from the patient, so it's usually gravity away from the patient for any humidified air or any drainage that occurs. And you want to avoid normal saline during suctioning. That sometimes can be an irritant or dry them out a little bit, so sometimes it's the sterile water that we use. Again, depending on the hospital policy, depending on if nurses are involved with that process or if respiratory therapy is responsible. We call it like a high-low, but it has an extra port that you can connect suction to, so that the back of the ET tube that sits right in the trachea has a continuous suction or an intermittent suction, so that any saliva or any anything that, whether it's from cleaning the mouth or the patient's own saliva, is just suctioned out, so there's no way for it to go into the lung cavity. We want to be cautious on sedation and weaning protocols, using aseptic technique when performing suctioning. A lot of them have suction tubing with a supportive device over it, so it's kind of like an inlining suction tubing, so that it's not reintroduced to infection. It's just only the patient's flora is exposed. Those need to be exchanged every so often. So I believe the protocol for that, I want to say that they are supposed to change those out like every 3 days, whereas the suction tubing itself and the canister, nurses are supposed to change out every day. We want to be on top of these patients' nutrition. If you have a patient that's been intubated for any more than even a day, we want to advocate and try to get the doctor to consider feeding tubes to help them be able to build their immunity and fight off any infection and have the energy to do so. We don't want them to just sit and kind of deteriorate. Also mobilization, whether that's by us or physical therapy, depending on the facility, but we want to do good range of motion, reposition them regularly. When I talk about spa treatments for intubated patients, I give them a nice massage, I lotion them up, I give them a nice bath, I just help increase any circulation on their skin surface. I move their arms around. I'm always constantly, because we usually have them in restraints, I'm always kind of bending their fingers and rotating them, and their ankles and their toes, because they can get kind of stiff if they're intubated for long periods of time. That's ordered. Sometimes it's a broad spectrum, waiting for the cultures to come back, and then that can be changed. Patients with early onset of VAP may be placed on a narrow spectrum, usually like ceftriaxones or fluoroquinolines, ampicillins. Patients at risk for resistance, any type of resistance, can be put on like a bigger, stronger antibiotic treatment, something like an anti-pseudomonal fluoroquinoline or something like that. Antibiotics are subsequently adjusted based on the culture results, like I said, but initially treatment should not be delayed. So if they've spiked a temp or their sputum has changed or there's a reason for us to culture them to begin with, usually the doctor will do a broad spectrum and then wait for the cultures to make a decision on changing it. COPD's description is airflow limitations, and it's not fully reversible. It's usually progressive. COPD exacerbations and other coexisting illnesses or comorbidities contribute to the overall severity of this disease. Abnormal inflammatory response of the lungs, primarily caused by cigarette smokes and other particles or gases. Independent disease, and that's the presence of cough and sputum production for at least 3 months in each of 2 consecutive years. It is an independent disease and it may precede the development of airflow limitations. Emphysema, just as a reminder, it's the destruction of the alveoli, and the pathologic term explains only one several structural abnormality with COPD. So the emphysema, remember those alveoli are kind of scarred, they're kind of overextended, so they can't exchange the gas as well. Their role is impeded by the structural deterioration. That's kind of what emphysema is. And treatment for both are different. It's the third leading cause of death in the United States. So, an estimated 12.7 million adults in the United States over the age of 18 have COPD. The number of people with COPD is greatly underestimated because the disease usually is not diagnosed until it's moderate, their symptoms are moderate to advanced. It kills more than 133,000 Americans each year. Chemicals or dust, some of your fighters that are exposed to some of those toxins, people that work around chemicals that don't wear protective gear. Air pollution can be a cause. Severe recurring respiratory infections. The A1, let me see if I can say this right. Antitrypsin deficiency is an autosomal recessive disorder, and that also is a risk factor for developing COPD. So some of it can kind of be genetic. Some degree of emphysema has been thought to occur as the person ages, right? So just kind of the wearing on the alveoli and its workload, that can kind of happen naturally, some wear and tear. It is caused by changes in the lung structure, respiratory muscles, and even if you're a non-smoker. COPD should be considered in any person who is over the age of 40 who's smoked more than 10 years, and that's a significant amount, like well, I guess that's not what the slide said, with a smoking history of 10 or more pack years. And I don't know if that's a pack per day. I'm not sure. But if they have if they're over 40 and they have a significant smoking history, that should be tested and that should be considered for that patient. Is how one obtains it and kind of the mortality rates involved with that. So some common characteristics: excessive mucus production resulting in chronic cough is a feature of individuals with predominant chronic bronchitis. However, not all COPD patients have sputum production. When present, excess mucus production is multifactorial, including an increased number of mucus-secreting goblet cells and enlarged submucosal glands. There's a dysfunction in the cilia and the stimulation of inflammatory mediators. So not always will you have the production of sputum or the ability to produce that. Thicken with advanced disease and pressure in the pulmonary circulation increases. Because the loss of the alveolar walls and the capillaries surrounding them, pressure can increase in the pulmonary circulation. This, along with the thickening of the blood vessels, can result in pulmonary hypertension. Diseases include the skeletal muscle wasting or cachexia, osteoporosis, diabetes, metabolic syndrome, all of which cannot be readily related to smoking. But there are other comorbidities or coexisting cardiovascular diseases that can contribute to this. And remember, with COPD patients, sometimes there's different types, right? The pink puffer, the blue bloater, whether it's affecting the alveoli more or if it's affecting kind of the cilia, and if they're having a harder time, like the overstretch of the pulmonary system, and so they retain more and more. Those are the patients that we teach the pursed lip breathing to, that have kind of a stiffening of the walls of their pulmonary system. So having the understanding of the difference between the two and what their symptoms might look like, you know, the barrel chest, the clubbing of the fingers, and just the difference in the two. In concentrations that vary with the person's respiratory system. So that would be low flow. High flow would be fixed concentration. An example of that would be the Venti or Venturi mask. We're going to show some pictures. Again, this is very fundamental block one review. It's very important with the COPD patients that we're aware and cognizant of the type of oxygen therapy that we give them. Sometimes we need to advocate. The doctors will put them on an oxygen protocol, which might not be appropriate for these patients. Remember, if they are retaining, they can actually have oxygen toxicity, or we can deplete their respiratory drive and they'll actually stop breathing. So it's very, very important that we know that they need very low flow oxygen. Now, if they're in an acute exacerbation, obviously for a temporary amount of time, we may increase those oxygen levels, but to make sure we wean them back down is crucial for that patient's survival. These patients, that's that top left picture. The middle picture, you see how there's that little like medallion looking thing at her chest? That's an oxygen reservoir. So they may be getting 2 liters of oxygen from the wall, but oxygen will hold in there so that every time they go to take a breath, they're receiving full oxygen. That's usually an oxygen administration that you'll see on a pulmonary artery hypertension patient. I saw that most commonly with them. The one on the far right, that would be considered a simple face mask. Again, you need to know how many liters of oxygen you can give with each of these. So your nasal cannula is 1/2 liter, 1 liter to 6 liters. Then you start to just dry out their nose. And then you would move to a face mask. Face mask can be on a very minimum of 4 liters. Most facilities require a 6 liter minimum for that face mask, and that can go up to 10 liters. Then that bottom left picture is considered a non-rebreather. Again, there's a reservoir. That bag is a reservoir of oxygen. You're administering it properly when the bag's inflated like that. That can go up to 15 liters, and that is you don't like a minimum 10 liters, maximum 15 to 20 liters. And that reserve has oxygen. So every time they go to take a breath, they're getting 100% oxygen. Nasal cannula. This would have to be specifically ordered from the physician and generally managed by the respiratory therapist. It sits in the nose, the prongs sit in the nose similar to a nasal cannula, but it's just at a higher concentration and higher flow. I have not seen these very often, especially with COPD patients. Mask is the bubble humidifier, which some of you may have seen. Another means of administering humidified air is a nebulizer. That just delivers like a water mist or an aerosol. The humidity can be increased by heating the water, and it kind of just creates a moist environment. Sometimes this is used for long-term effects of oxygen therapy. If you think about someone that's needing constant airflow into their nasal passageway, that it can become kind of dry and very uncomfortable. I've had several patients, especially pulmonary artery hypertension patients that are oxygen dependent, get pretty significant nosebleeds from just irritating their nasal passage. These patients, especially if they're COPD patients and have a history of smoking, a lot of education needs to be done, especially if they're home oxygen. Any fire flame cannot be close to the oxygen. It can combust. I have an unfortunate story about that. We had a trauma patient that came in who was on nasal cannula, younger kid, early teens or late teens, early 20s. He had his friends come in to visit, and for whatever reason, they thought it would be a good idea for him to smoke a cigarette in the hospital. So they had the door closed and the curtain closed. He lit up a cigarette and it actually combusted, and he had like second-degree burns across his face where the plastic had basically melted into his skin. So you want to make sure that you are educating your patients about that. CO2 narcosis. So normally CO2 accumulation at the chemoreceptors is a major stimulant of the respiratory center. Over time, some COPD patients with hypercapnia develop tolerance or high CO2 levels. The respiratory center loses the sensitivity to the elevated CO2 levels. So in theory, for these individuals, um, a major drive to breathe is gone, so hypoxia can form. So we want to make sure, again, we're talking about these CO2 retainers, that pulse oximetry and or ABGs are used to determine the amount of oxygen that they're receiving, if they're compensating appropriately via their ABGs. Venturi masks may be used because it has a tighter regulation on the amount of oxygen that's being administered. Um, and the goal is a pulse oxygen saturation of at least 90. So we kind of change our expectations a little bit with patients with COPD, that above 96% or above 94%, we actually want to keep them at a lower range. If we get them in those high 90s, we need to consider how much oxygen are they getting? Do we need to come down on it? Are we creating further problems for these patients? Pulmonary O2 toxicity may result from prolonged exposure to high levels of oxygen. So again, say we have a COPD and we're giving them high, prolonged amounts of high oxygen, but their numbers still aren't necessarily adjusting, we can be causing further damage to them. Absorption of atelectasis. So when high concentration of O2 is given, nitrogen is washed out of the alveoli and replaced with O2. So if airway obstruction occurs, the O2 is absorbed into the bloodstream and the alveoli will actually collapse. So you also want to be very careful of that we can, because of absorption issues, we can cause atelectasis with a patient with an existing lung disease. Wouldn't be good. Infection can be a major hazard of O2 administration. So heated nebulizers perform constant humidity, which kind of, bacteria likes warm, dark, moist environments. So we're kind of creating an opportunity for a pseudomonas or for some kind of sinus infection or even respiratory infection. That's happening. We talked a little bit about oxygen therapy for treatment. Obviously, there's more treatment than that. These patients can be on steroids, they can be on bronchodilators, they can be on guaifenesin. There's just different things depending on their symptoms that they can have long-term treatment on. I didn't go into that in a lot of detail because we're really wanting to focus ours on acute exacerbation and long-term effects or end stage. So there are some surgical treatments that are available. So they kind of go through those, and then ultimately a lung transplant would be the ideal situation for a patient truly suffering with COPD symptoms. So surgical therapy, there is the lung volume reduction surgery. It allows the diaphragm to return to its normal shape, allowing the patient to breathe more effectively. And what they do is they remove part of the diseased lung. So studies would have to be done, CT scans, bronchoscopies to kind of determine if this person would be a candidate. Lung volume reduction surgery is being explored as a therapy that can be performed via a bronchoscope. But the idea is that it will result in decreased airway obstruction and increase room for remaining normal alveoli to expand. Volume reduction surgery. A one-way valve. One-way valves are placed in the airway leading to the diseased parts of the lung. So the valve lets air out but not in. So this collapses a certain segment of the lungs and is similar results of actually doing the surgical procedure of the LVRS. A surgical transplant of the lungs, a single or both would be considered. This would help prolong the patient's life. If they have reversed the causing agents of the COPD, they can have a pretty normal life. If it's a genetic thing, then they usually wouldn't be a candidate for it, depending on the age that they're being affected and what other comorbidities they have. The exacerbation. Remember, our goal is to get them back to their baseline. Hospitalization can be required if they are having an acute exacerbation, a pneumonia, cor pulmonale, or acute respiratory failure. The degree and severity of the underlying respiratory problem should be assessed and treatment should be initiated soon. Again, we have to be careful with these patients with their oxygen treatment and oxygen therapy. They may come in with their saturations really low in the low 80s. And again, our goal is not to get to 100% sats. We want to get them into the high 80s, low 90s, but you'll follow your physician orders for that. But you should anticipate that a patient in a severe exacerbation, that mid to high 80s would be acceptable. The case manager, the doctor, pulmonary rehabilitation is an option for these patients, especially if they're having recurrent episodes. We want to make sure that they're properly educated and that they're prepared to take care of themselves on their own to prevent readmission to the hospital or recurrent episodes. We want to teach them about their activity, how to rest, how to cluster their care, how to modify their activity. Sexual activity, they're going to need to be educated that they should choose this activity depending on when they're breathing the best. And we want to teach them pursed lip breathing, especially when it comes to any type of activity that's going to increase their respiratory rate. Their sleep is going to be interrupted with a lot of the medications we give them and the steroids we give them. So these patients don't get traditional 8 hours of sleep. They get a lot of cat naps and interrupted sleep. So those are all things you want to consider. Pulmonary rehabilitation can be done in an inpatient or outpatient setting or even in their home. It works best if the patient starts it when COPD is in the moderate stage. A mandatory component of pulmonary rehabilitation program is exercise that focuses on the muscles used in ambulation. Our goal is to keep them moving best we can. Pulmonary rehabilitation and interprofessional team, they work together to individualize the treatment plan for a COPD patient. Physical therapists or nurses have experience with pulmonary care, often responsible for the management of pulmonary rehabilitation centers. A large part of your role as a nurse in this environment is to teach the patients self-management of their disease. I think psychosocial considerations are very important with a patient with this type of disease. People with COPD frequently have to deal with many lifestyle changes that can involve their ability to care for themselves. So they need a caregiver, someone to help them. They have decreased energies, so they can't go do social activities. They may not even be able to work sometimes. So there's a lot of coping that they need to develop healthy coping strategies. It's important to convey the sense of understanding and caring to the patient. The patient with COPD may benefit from stress management techniques, so massage, muscle relaxation, meditation. We want to teach these patients about the treatment and disease. So we want to have them have that autonomy to feel like they have some control or some independence. Support groups at local American Lung Association chapters can help these patients as well. End-of-life considerations for these patients. Symptoms can be managed, but the COPD cannot be cured. So any symptom that we can manage, we want to help advocate for that patient. End-of-life issues and advanced directives are important topics to discuss with these patients, preferably early on in the disease and not until the last minute. They should know that this is a progressive disease, that there is no cure for it, and they should be kind of moving into terms of acceptance about that. Palliative care, end of life, and hospice care are important in advanced patients in advanced COPD. We want to keep them as comfortable as possible. Like I've said before, these patients can come into the hospital in an acute exacerbation. They may need temporary ventilation, maybe temporary aggressive steroids or antibiotics if they've gotten a pneumonia or something like that. So you may see them in the hospital setting. Medical professionals try their hardest not to have to intubate a patient with COPD. These patients become very difficult to wean off the ventilator. If you think about their lung capacity and the lack of function of their lungs, and we take it over for them and the ventilator does the work, their body likes that and their body responds well to that. and we don't want to have them on machines for a prolonged amount of time. So we may choose, the doctor may choose a CPAP or a BiPAP to help manage acute episodes in these patients to avoid intubation. Again, in acute episodes, some of our expected outcomes, our goal is to get them to return to baseline respiratory function so that they can be discharged home. They need to demonstrate an effective rate, rhythm, and depth of respirations, experience clear breath sounds, or at least back to baseline if their baseline's wheezing, maintain clear airway by effective coughing, and then we want their ABGs to kind of normalize. This is, again, depending on how advanced their COPD is, some of these things will vary, right? So if they're at beginning stages, obviously all of these would be anticipated, but our goal truly is to get them back to their baseline so that they can go home and continue to manage the disease on their own. The acute episodes are usually triggered by bad weather, an allergen exposure, a pneumonia, something to that effect. Non-compliance with their steroid medications or bronchodilators can also be a cause. But there's usually a reason why they're having an acute episode and why they're coming into the hospital with it. And so our goal is to try to get them back. The expected outcome is to get back to their baseline so they're able to be discharged home.